but I can give a recap.
Yeah, please, yeah.
Okay, so we talked about the cells of the immune system, where we said that where all these cells are made through hematopoiesis. So there's one major stem cell, which is the pluripotent stem cells, and then from there you get the lymphoid and the myeloid progenitor cell. From the lymphoid, you get the B cells, NK cells. From the myeloids, you get the erythrocytes, you get the platelets, and you get the granulocytes, which is eosinophils, basophils, and neutrophils. Then we talked about the innate and adaptive immunity, where we said the innate immunity it's not specific and it doesn't have any memory, and it's the first line of defense. So there are different, like the first line of defense is like our skin and our mucous membranes. Then second line of defense is now what is the second line? Gaius, anybody?
It was the chemical barriers and such.
Yes, yes, yes. Then the third we said was like the biological barriers, like lactobacilli. Yeah. So, mm, yeah, then we say the cells that are involved in the innate immunity are phagocytes. Yeah, phagocytes, which is neutrophils and macrophages, and also NK cells. So when you're infected with the bacteria, neutrophils are the ones that will be your first line of defense as for your cells. Then for chemicals, you'll have like the complement proteins and the cytokines. Then you'll also have like inflammation and fever. So for inflammation, this was just like an added point. I don't know if it was discussed yesterday. Or actually, it was inflammation is caused when there's increased prostaglandins, histamines, and bradykinins. So what these do that is that they dilate the blood vessels and increase the vascular permeability. Now this causes those 4 or 5 cardinal signs of inflammation, which is redness, heat, pain, swelling, and loss of function, which is like the fifth one. Then fever also. Fever is when like pyrogens are stimulated and they travel to the hypothalamus. So the hypothalamus is the one that regulates our body temperature. So it increases your temperature. Why we get fever is because when there's high fever, the the function of an immune cells increases. So that's an advantage, because then the pathogen reproducibility will also be less. Then adaptive immunity, there's humoral and cell mediated. In the first one, you have like all in the first one you have MHC1, MHC2, and CD4 cells involved. And then in cell mediated, you have MHC1 and CD8 cells, which is the T cytotoxic cells. Then we also said that some of the properties of adaptive immunity is it is specific, it is diverse, it has memory, specialization, contraction and hemostasis. It doesn't react to itself, and clonal expansion. Then we also talked about the different types of antibodies. IgG is one of the major ones, where it's the highest in concentration in our blood. It is a monomer and it's the only one that crosses the placenta. It also activates the complement, by the way. Then you have the IgM, which is a pentamer, and it's involved in the ABO blood grouping. Then you have IgA, which is mostly in like our secretions. IgE is mostly for parasitic infections, and it's mostly related to like allergy. So IgE is the one that I think binds to mast cells, and and mast cells will release histamine, so causing an allergic reaction. Then you have the last one, which is IgD, and that one we say that IgD is a B lymphocyte receptor, and it is also a monomer. So all of them are monomers except IgM. Yeah. Then we talked
And
about
Nani
sorry?
Hiral.
Yeah.
Just so even IgG is a monomer. It's not a dimer.
Yeah.
It's not a dimer. I thought one of them was a dimer.
Or I'm confusing myself.
Uh, uh,
Let
okay,
me let me check.
I will just nene because I thought let me also check my notes because I thought in Gontia's notes it said IgG is a
Oh,
dimer.
was it?
And nice, I'm seeing professor is in the building.
Yes,
Uh,
sorry. Sorry. Yeah,
uh-huh.
IgG is a dimer.
IgG is a dimer, IgM pentamer, the others are monomers.
No. Yes, sorry.
Okay. I think because now Kigo has arrived, I think we'll hand it over to the
Okay,
good
fine.
professor to take us through. Thank you, Hiral.
Okay. Hi guys, can you hear me?
Yes, we can
Yes,
hear you.
Nico.
Oh, okay. So thank you. So, before I start, like, you remember hematology was a very bulky unit because even Gaius's girlfriend, Professor Orata, used to just keep complaining how we're doing it as one unit because it's a thing that takes years to cover. So it really has a lot to it, but I've tried looking for resources that kind of summarize so that we can just go by it as quickly as possible. So one of the documents that I found, let me just share my screen. Can you guys see?
Yes, we can see.
So this is just it's a book. It summarizes this whole thing in under 200 pages. I looked at it and I saw that it basically covers everything we need to know. It has nice illustrations that go straight to the point. So it's good for revision. So I'll try to go through it as fast as I can. These first few slides or pages basically have stuff that the body. We know the pH. This is just stuff that we know, the functions of blood, which include distribution of oxygen, metabolic waste and hormones, regulation of temperature, pH, fluid volume in the circulatory system. It protects through its function of the function of the platelets, which are blood components. So it protects from severe hemorrhage. White blood cells also prevent the body from getting attacked by infections. So in the components of blood, we know that blood has mostly cellular components that are suspended in a liquid. So this is the process of extracting plasma. So plasma is the liquid content of blood. And then if you centrifuge blood, the solid components, which are the cells, of course, will be pulled to the bottom, so it enables separation. So the plasma is a straw-colored sticky fluid that is mostly water. It contains very many dissolved components that are required for the body, like ions, hormones, of course. These are the non-solid components that will not go to the bottom after centrifugation. The difference between plasma and serum is just that serum does not have clotting elements, but plasma also includes the clotting elements. That's just the major difference between plasma and serum. So we know the types of cells that are present in blood. I don't think I'll go through that because we'll still cover it either way during hemopoiesis. So as we head towards starting hemopoiesis, we can discuss where various blood components are formed. So for erythrocytes in fetuses, it has 3 stages. Between 0 and 2 months, it's in the yolk sac. 2 to 7 months, as the fetus develops, they have already developed a liver and a spleen. So those are the major sites for formation of red blood cells. And then 5 to 9 months, it's in the bone marrow and the liver. In infants, it's the bone marrow of most bones, but in adults, it's the bone marrow, majorly the long bones, the vertebrae, the sternum. Yeah. Okay. Leukocytes formed in the bone marrow. Most of them, there are different ones, as we know, the DNEs. So they all come from the same, let's call it parents, which is they are from the myeloid lineage. We will just see it in a few moments. And then we have lymphocytes, also from the bone marrow and also the thymus and other organs like spleen, lymph nodes. Yeah. This one is, I think we'll see. Okay, so hemopoiesis or hematopoiesis is the formation of cells in the blood. We've discussed where the sites of formation are for different types of cells. So hemopoiesis starts with what is called the pluripotent stem cell. The pluripotent stem cell can either take one of 2 channels, where it can either go the myeloid way or the lymphatic way, the lymphoid way, sorry. So the myeloid way is what leads to our leukocytes, our red blood cells, our platelets, monocytes, neutrophils. But the lymphoid way majorly leads to the formation of lymphocytes and the natural killer cells. So what directs this, the channel that is taken by the pluripotent stem cell, is the colony growth factors, and what are they called? The colony CFUs. No, that's funny. Colony stimulating what? Forgotten that.
I think it's factors too.
Yeah.
Yeah.
So they're the ones that direct which side growth will grow, depending on maybe the needs of the body. So this is just a diagram illustrating that. You can see the stem cell, the pluripotent stem cell here. When it comes like this, we have you can either go the myeloid way towards the mixed myeloid progenitor cell. The DFUs, what are DFUs? Oh my God. This is the in theory, red blood cell formation. So it's a sequence of amplification and maturation. So the pluripotent stem cell gives rise to the CFUs, BFUs. So this is just for the erythrocytes. So it's going to use the BFUs. BFUs are the first recognizable erythroid precursors, which are the chronomoblasts. Then after chronomoblasts, we go to the progressively smaller normoblasts. Then the reticulocytes, which are red blood cells with no nucleus, but they have DNA and RNA remnants. So as these ones mature, that's when they gain stuff that gives them, that's where they differentiate, if I can call it that, where they gain their function by developing the various components that they need, such as hemoglobin. So for red blood cells, it's going to be hemoglobin, and they also don't need the nuclear material, so it will also be shared as they mature. So we know reticulocytes from our blood tests are usually indicators of the continuous process of erythropoiesis, which, as we'll discuss or as we go on, is an indicator. It indicates that there is active erythropoiesis, and of course, it has a normal range for the number of reticulocytes you expect to see when you do a blood count. But a higher number of reticulocytes is very good for indicating that there's overdevelopment of red blood cells, which could indicate that there's a problem in the body. Either there's loss or there's dysfunction in red blood cells, meaning they're not able to produce enough of their function, which leads to the body keeping on producing more of them. So that's a good indicator. So the body will always try to maintain homeostasis. So keeps renewing the ones that either die or are not properly functioning. Okay. So erythropoietin is a hormone that is produced in the kidneys, particularly the peritubular interstitial cells. So it is the one that regulates erythropoiesis. Even pharmacologically, it's available as an injectable formulation. It's one of the things that was commonly implicated in athletics, where people were found to be injecting various levels of erythropoietin to increase their red blood cells, which increases their oxygen carrying capacity, meaning they have more endurance. So erythropoietin is the hormone that regulates erythropoiesis. So other requirements for the formation of red blood cells include metals, of course. We know iron is very important. We have vitamins like B12 and folic acid. So these ones are necessary for normal DNA synthesis. Amino acids and a hormone called erythropoietin. So we know the functions of hemoglobin. I don't think I really need to talk about that. When we talk about the constituent, it's made of a protein called globin that is bound to the red heme pigment, which is mostly the iron carrying pigment. So globin consists of 4 polypeptide globulin chain, each having its own heme group. So the chains are like this, they're 2 alpha and 2 beta. And the heme molecule groups contain protoporphyrin and 1 iron atom in the center. So hemoglobin is what carries oxygen. So as it passes through the lungs, it becomes oxidized to oxyhemoglobin, then it releases the oxygen at the sites where it's needed to become deoxyhemoglobin. Then carbon dioxide binds to the globin amino acid, doesn't bind to the heme group. So erythrocyte death, they have a lifespan of about 120 days. We know the relevance of this in its importance for the HbA1c test. It is a marker for that can be used to monitor glycemic control in patients who have diabetes to show just how well the drugs have been working. Has the blood sugar been controlled over this period, which comes to 120 days is 4 months. Yeah. So dying cells are removed by macrophages in the spleen and the liver. So the body tries to economize these components. So the iron is used. It is taken back to the bone marrow. So the process of taking it back includes it being bound to transferrin. Then the transferrin takes it to the bone marrow where it's stored as ferritin. The protoporphyrin, which is now the heme without iron, is metabolized to bilirubin, then conjugated in the liver, which is now, then it's converted to bile. So as we're still dealing with our red blood cells, we can now start going to the conditions that are involved in problems with red blood cells. So the major one is in 1 minute. Sorry. You guys can still hear me?
Yeah, we can.
Okay. So the first problem we'll encounter that is faced by red blood cells, caused by red blood cells, is anemia. So anemia can generally just be explained as a lower than normal hemoglobin concentration. So we have there are 3 common types of anemic combinations. We have microcytic. Okay, you can describe red blood cells based on these 2 parameters, their size or their pigmentation. So we can have small sized red blood cells, which are the microcytic ones, normal sized are the normocytic, and the large size are the macrocytic. And then the colors and pigmentation is just the same, hypochromic or hypochromic. So the microcytic and hyperchromic types of red blood cells are just a small red blood cells that do not have a lot of pigmentation. So these are the major indicators of iron deficiency or iron deficiency anemia. As we saw in the previous pages, iron is very important during the formation of hemoglobin. So reduction in iron can cause this type of anemia. Chronic inflammation can also lead to microcytic hypochromic anemia. So the lack of iron release from macrophages in the bone marrow into plasma leads to a reduction in the red blood cell lifespan or reduction in erythropoietin response, which leads to, of course, reduction in the production of the red blood cells. Sideroblastic anemia is also characterized by this type of disease. This is where the protoporphyrin, what was it called? The heme portion without the iron. So once its formation is problematic, it leads to sideroblastic anemia. And then we have thalassemias, reduced synthesis of alpha or beta globin chains leads to hemoglobin disorder, and then which also leads to ineffective erythropoiesis. Increased hemolysis, maybe due to aggregation of unmatched globin chains, which means that the red blood cells formed will be flagged as not properly functional, meaning they will be destroyed by the spleen. So this increase in hemolysis will cause the high red blood cell turnover. I said, yeah. So thalassemias can be of two types. We have alpha thalassemia or beta thalassemia. So alpha is deletion of one or more of the 4 alpha globin genes. Remember, there were 2 alpha and 2 beta. And then beta thalassemia is caused by mutations in the beta globin genes. So prevents B chain formation. So they're named depending on the globin chains that they affect. Nomocytic and nomochromic red blood cells does not always mean that the red blood cells are healthy. So it can also mean that there are still underlying problems. Okay, it's not very serious for these ones, but it is something that is worth mentioning. So this can be seen in anemia that is due to acute blood loss. So, once there's loss of blood, the body will quickly try to make more red blood cells to replace the ones that were lost. And so, yeah, it might have anemia. It's not as serious as I mentioned, but it's still mentioned. So this is also something else I found is that in pregnancy, it is also possible to find something like this due to, in pregnancy, there's usually an increase in the plasma volume. And the increase in the plasma volume can cause something. You remember, like how we mentioned in class, there's something called dilutional hyponatremia. So it can also cause dilutional anemia if the mother, that's why supplementation for folate and for iron, I think it's called IFAS, is important for pregnant women. The next thing is you can have macrocytic and normochromic red blood cells. So this one is typically from defective nuclear maturation of erythroblasts. This is due to defective DNA synthesis, and we saw that the components that are important for DNA synthesis there was vitamin B12 and folic acid. Alcoholism is also another cause of this type of anemia. So things that cause vitamin B12 deficiency B12 is mainly from animal products, especially the liver. So if you don't consume enough of that, factor like pernicious anemia, which is an autoimmune response to the peripheral cells of the stomach, which leads to reduction of the intrinsic factor, consequently leading to reduction of the absorption of vitamin B12. So intestinal issues like ileum, having your ileum resected or having Crohn's disease, of course, will affect the ability of your intestines to absorb some of these nutrients. that can lead to a problem. Another one worth mentioning is the parasite that was called Diphyllobotryum latum. So that one, it reduces, it like steals your vitamin B12. Okay. Causes of folate deficiency, of course, same thing, nutritional. Folate, on the other hand, you see how B12 was mainly from animal products. Folate is from plant products such as greens, but some of these ones, cooking them has a tendency of being a bit destructive to the folic acid, but the major sources of folic acid are veggies and these greens. So malabsorption, of course, just like in vitamin B12, excess utilization. So in patients who are pregnant or lactating or have chronic inflammation, the folic acid can be depleted, causing anemia. So for patients who have some of these problems, it's just important to replace supplement. Excess urinary loss can also lead to folate deficiency, for example, in acute liver disease or in congestive heart disease. Okay, so loss of folic acid through the kidneys. Other types of anemia include hemolytic anemia. This is abnormal destruction of the red blood cells. So this causes the lifespan to reduce. They don't reach around 20 days. And since they're being depleted so fast, at a point where the bone marrow cannot be able to keep up, like when destruction is more than production. So causes of hemolytic anemia can also be from other anemias, such as the macrocytic anemias or thalassemias. Can also be inherited, like cell membrane defects, like erythrocytosis. Let me just try to trace Professor Urata's notes. I think she showed us the different in her slides. Just give me a minute, guys. I traced them. You guys can see the screen.
Yes.
Okay. So these were the notes for the various problems that can occur with the red blood cells. So we can just start with this one. Poikilocytosis is a state in which there's an increased proportion of cells of abnormal shape. Just that. Spherocytosis. So they look like spheres. Red blood cells usually like have a sunken center, but the spherocytes just look like spheres. They don't have the central pallor. Can have elliptocytes. So elliptocytes are just have this shape, this oval shape. They are elliptical. Stomatocytes, some are mouth-like, caused by membrane defect. Can have dacrocytes, which are teardrop-shaped red blood cells. So these ones occur when there is bone marrow fibrosis or severe erythropoiesis. They're majorly seen in megaloblastic and thalassemia. Target cells, they are look like they have a bullseye. So caused by having redundant membrane, like extra membrane. Sickle cell, this one, the sickle shape. Can have basophilic stippling due to precipitated RNA or heavy metal poisoning. Have bast cells. This is just a general shape. They look like they have thorns or something. So they are caused by other lipids in the cell membrane. I can have schistocytes, like fragments. They kind of look like, when you look at them, they kind of look like platelets, but they're not platelets, they're schistocytes. Okay. You can also have inclusions such as the Howell jolly bodies, which are medium-sized round cytoplasmic red inclusions. That's an inclusions that have the same staining characteristics as a nucleus and can be demonstrated to be composed of DNA. It's a fragment of nuclear material in the erythrocytes. You can see what it looks like. These two black things over here. So you can also have nucleated red blood cells, but usually in normal functioning of the body, they're removed by the spleen. So we don't see many of them. But once for patients who undergo like a splenectomy, because now they won't be removed because the spleen is not there, you can have more of them than normal. You can also find them in neonates because the spleen has not yet fully developed, so it's not functioning as it should, meaning these cells are being removed. So you can see more of them there. You can also find them in pregnant women because of the placental exchange, basically because of the child's blood components being passed on to the mother's blood. So they'll also be included there. I also have red cell agglutination, just irregular clumps of cells. It looks like clotted blood, but this is blood that's in the body or that you didn't. Can also be an error where you didn't really handle your blood well after extraction. So these two, red cell agglutination and Jolot formation, you have to really be careful when handling blood after phlebotomy to avoid some of these things as a false diagnosis. So Jolot formation is coin shaped. It looks like a stack of coins. That cells they get that shape. So we can just go back to the other document. So anemia can also be acquired, can have autoimmune hemolytic anemia, which is where your red blood cells are destroyed, are perceived to be pathogens and destroyed. Isoimmune or blood type incompatibility, where if you're transfused with blood that is not compatible with you because of the antigen or antibodies present, you have a reaction, a transfusion reaction. Or you can have hypersplenism, where your spleen is overacting and removing too much of your red blood cells. Yeah, and if in these conditions your bone marrow is not able to keep up, you will exude the classic signs of anemia. So when it comes to hemolytic anemia, just as we've said, it's increased destruction of the red blood cells. So you can expect once they're destroyed, like the red blood cell components will be released to flow freely in the blood. So this can be used for diagnosing. So if you find like high levels of free hemoglobin in the blood, it can help you determine that this is most likely hemolytic anemia, whether in blood or in urine. If they are higher than normal levels of hemoglobin, you can just tell that it is hemolytic anemia. Hemolytic anemia can also lead to red brown urine. It can be due to these other conditions that are parasitic, something like schistosomiasis, bilharzia, or even malaria. So these ones also lead to hemolytic anemia. The other type of anemia is sickle cell anemia. It is an inherited disease that is most common in Afro-Caribbean populations. So it's caused by abnormal beta hemoglobin chains. So the abnormal hemoglobin is insoluble and it forms crystals at low oxygen tension. So this leads to the characteristic shape of this red blood cells, which is just this sickle shape. And because of their lack, they also lack, they have too much turgidity, and they have a lot of the shape is not ideal for traversing the capillaries because of how small they are. So they have a tendency for clogging capillaries. Then once they clog capillaries, there's an area that will not receive blood. So the area will have hypoxia, which can definitely lead to tissue necrosis. Anyway, so we can just go on. Ways of measuring anemia. We have MCV, which is the mean cell volume. This is just the average size of the red blood cells. As we said, it can be microcytic, normal, or macrocytic. You can have the mean cell hemoglobin. This is the average amount of hemoglobin in the average red blood cell. MCHC, which is the mean cell hemoglobin concentration. This is the average concentration of hemoglobin in a given volume of blood. You can also do your staining. So staining will reveal the color as either monochromic or hypochromic. So type some stain that I used. I remember we had the Romanowski stain. Yeah. So these are the part we said you can have microcytic, normal, macrocytic. Polycythemia. Polycythemia is increased production of red blood cell. Okay, let me just read it. Absolute polycythemia, the first type of polycythemia, is an increase in red cell mass caused by increased erythropoiesis, which may occur as a compensatory physiologic reaction or response to tissue hypoxia, or as a principal manifestation of polycythemia vera. So this is what happens when like mountaineers go climbing because of the reduced level of oxygen or air thinning. So it means that oxygen levels there are low. It's mostly a normal reaction. And it's what leads to, if your bone marrow is slightly unable to keep up, you can get what's called altitude sickness, where you find people get fainting episodes when you're climbing a mountain because your brain is becoming hypoxic. Then we can also have relative polycythemia. This is a decrease in plasma volume without changing red blood cell mass, so that the erythrocytes become more concentrated. It's an elevated hematocrit. Hematocrit basically means ratio. It's like a ratio of the total volume of blood that you took to the total volume of red blood cells after they settle. So it gives what percentage of the blood, helps to give what percentage of the blood is the red blood cells. You can also have another condition called hemolytic disease of the newborn. So it's a condition that develops in the fetus. So the mother's IgG anti-RHD antibodies cross the placenta and attack the fetus. So they attack the red blood cells of the fetus. So the red blood cells get broken down. The fetus can develop reticulocytosis, anemia, death. It will be chronic anemia. So how it happens is when you have a mother who's neg and the father is positive. So during mixing of the blood at the placenta, since the mother is neg, she will have the antibodies, not the antigen. So the mother's antibodies attack the antigens present in the child. But this used to be a serious problem like in the past, and find many traditional communities would have, I don't know, stillbirths or miscarriages, but I didn't know. So as times have come along, we've been able to get the vaccine, like a rhesus D antigen. So it reduces it helps avoid this attack on the fetus. So the mother, you take it before pregnancy, when you're trying to conceive. This one we've explained. We can just, this one is just the findings that you find. You know, there will be because of the destruction of the red blood cells. Okay. So we'll go to the lymphocytes. Lymphocytes circulate between blood and lymph via a network of small lymphatic vessels. They collect interstitial fluid and return it to the large veins near the heart. They also connect to a chain of lymph nodes and organs within the lymphatic network. So if there's inflammation, the lymphocytes stop in a regional node, proliferate, and take part in the immune response in the area. We saw in the formation how they are formed. They are now from the lymphoid pathway. So for problems that involve the lymphocytes, these are mainly now the malignancies. So you can have the Hodgkin's and the non-Hodgkin's. So can just start with the Hodgkin's, but I know this one will be covered again during the clinical pharmacy for the cancer and anti-metastatic agents, but you can just mention it. So Hodgkin's is characterized by the presence of Reed-Sternberg cells. which are bi or multinucleated cells derived from lymphoid cells. And then it's also characterized by the spread of the disease from one lymph node to another, which leads to the development of systemic symptoms. So this one is more common in males, most common in males, either in young adulthood or late adulthood. Clinical signs are asymmetrical and painless lymphadenopathy, which is just swelling of the lymph nodes, have fever, sweating, weight loss, and fatigue. So for all these conditions, you diagnose them by doing your blood test or doing your bone marrow aspiration. So definitive diagnosis is by lymph node biopsy. Since these ones affect the lymph nodes, you can just get a portion of the lymphatic tissue and observe under your microscope. Then if you see the presence of the Reed-Sternberg cells, it means it's Hodgkin's lymphoma. So treatment, I won't really talk so much about this. It's radiation or chemotherapy. That one, the various that we discussed in lymphoma. Then the other type is the non-Hodgkin lymphomas. So this one's a diverse group of hematologic cancers encompassing any lymphoma other than Hodgkin's lymphoma. So if there are no Reed-Sternberg cells, it falls under non-Hodgkin's. Do you guys feel like we should go deep into the classifications for these Hodgkin's lymphomas? Hello? Okay. So that we will read for yourself if you want to know how these non-Hodgkin lymphomas are classified. But these ones, they can occur at any age and may be aggressive or benign. So the clinical signs for most of these ones, it's initially painless, lymphadenopathy, the swelling of the lymph nodes, but pain develops as time goes. Then subsequent signs depend on infiltration of other body systems. So the infiltration of other body systems will lead to now the other signs and symptoms that are maybe for those systems. Diagnosis is like this, just like the other one, physical exam, the lymphadenopathy, splenomegaly, hepatomegaly, blood tests, bone marrow tests. So you need to do your bone marrow aspiration and observe. You can also do a CT scan or lymph node biopsy. Treatment, we've said it will be covered. It's mostly chemotherapy. Even this one, multiple myeloma, I won't go much into it. You just need to know like what it is, but it will still be covered again. So this is just a condition characterized by proliferation of plasma cells in the bone marrow, leading to overproduction of immunoglobulins. So this condition is usually often asymptomatic, but having excess immunoglobulins can block your renal tubules, leading to like kidney damage. And then the immunoglobulins also break down the bones. So this leads to bone pain. And remember, during that unit, when we're doing these things with Amsalu, was these things you need to give, what are they called? The drugs that reduce your calcium. Anyway, I know that will be discussed in Clean Farm. We'll go deeper into these things. Myelodysplastic syndrome is another condition. It's also a diverse group of hematological conditions characterized by ineffective production of myeloid blood cells. Common in the elderly patients. Clinical signs include bone marrow failure, which leads to abnormalities of all the three myeloid lines. So it will lead to what is called pancytopenia, just reduction of the levels of basically all the blood components. So it often leads to acute myeloid leukemia. We just go to leukemias. For leukemias, let me try to use Orata's notes. I found them to be a bit more comprehensive. You guys can see.
Yes.
Okay. So white blood cell disorders. She started with leukopoiesis. So this is just formation of the leukocytes. We know that there are different types. We have the basophils, neutrophils, eosinophils, monocytes, macrophages. So the BNEs are usually known in general as the granulocytes because they're granulated. So white blood cells that appear in circulation are part of two distinctive cell pools. We have the marginating pool and the circulating pool. So the marginating ones are those located along the endothelium, ready to migrate to the site of injury or infection. And the circulating ones that are in the bloodstream, moving from place to place. So the stages for growth and differentiation for the leukocytes. There are 5 for neutrophils and 4 for eosinophils and basophils. And then monocytes and lymphocytes have 3. So for neutrophils, we have the myeloblast, followed by promyelocytes, then myelocytes, metamyelocytes, the burned cells, and the segmented neutrophils. Anyway, and just go to leukemia. So leukemia is a cancer that starts in the bone marrow and the lymph system, the organs that make blood and blood components. So hematopoietic stem cells in the bone marrow can either continue or give rise to progenitor cells that generate precursors. So the hematopoietic stem cells can make more stem cells, or they can, as we said in the beginning, choose to go either the myeloid way or the lymphatic way, leading to formation of all these cells. So leukemia is just the leukemic mutations interfere with transcription factor functions, abrogate cell differentiation, and support proliferation. They just leukemia mutations just affect how the components of the blood are made, thus leading to either immature cells of different kinds or non-functional cells. So AML, acute myeloid leukemia, is an example of a cancer that is characterized by a differentiation block. So this is where the cells do not differentiate. So leukemias can be characterized as either acute or chronic based on their clinical features, or can be myeloid or lymphoid based on the morphological cells involved. So it's like this: leukemia, acute, chronic. So for the acute, you can have acute AML or acute lymphoid ALL, or the same for chronic. So these are the things I was telling you for the classification. We have the FAB classification. I won't really go too deep into that. We'll just mention Juju. So pathogenesis, chromosomal abnormalities, radiation, chemicals, viruses. These are all things that can lead to leukemia. So exposure to radiation, some chemicals which affect your bone marrow. There are also viruses that can cause this. Or even genetic factors. Just a second, guys. Okay, can go on. So when it comes to the clinical features, this is AML can affect any age or any sex. It has indistinguishable features, like you can't distinguish most of these leukemias from each other based just on physical findings. You'll have anemia, you'll have repeated or common infections. So you're basically some of the infections that you will not find people complaining about because the immunity is able to fight them. If in a normal state, you find now them complaining of such infection, but is being diagnosed with some of these infections. You can also have bleeding manifestations, lymphadenopathy, hepatosplenomegaly, and then bone pain or tenderness. So most of these clinical features are because of the, what's it called, problems, pancytopenia, problems in the development of all the kinds of cells. So you'll see for the anemia, you can tell the red blood cells that are responsible for this. Infections because of the white blood cells or the reticulocytes, granulocytes. So the bleeding manifestations, platelets. So most of these just are related to the cells involved, the clinical features that is. So lab features, some of the tests you can do, you can do a full hemogram. It will show you the pancytopenia that we're talking about. You can also do a peripheral blood film to just observe the blood cells under a microscope. You can already imagine how many immature ones you find for such a diagnosis. Most of them will be either immature or with visible problems. You can also do a bone marrow profile. Bone marrow aspiration, just see how it's functioning. You can do cytochemistry, immunophenotyping, or cytogenetics. Okay. Going to acute leukemias. So these ones are the results of accumulation of early myeloid or lymphoid precursors in the bone marrow, blood, or other tissues. So as we've said, it's lack of differentiation or lack of development, proper development of the blood cells. It's not, these are just the statistics. So we go directly to AML. So AML can just tell you it's myeloid. So myeloid meaning to mostly affect the RBCs, white blood cells, platelets, yeah, just all those ones. So the malignant myeloid cells, called the myeloblasts, they don't mature into the different types of blood cells. So these myeloblasts are the ones that you find in free circulation. So of course, since they have not differentiated, they won't do any of the functions that they're supposed to. So you can just tell because of this, but the pancytopenia will be present. So you'll just have this symptoms related to the lack of proper functioning of all the cells. So this one is the classification is done by the FAB classification system, which is done by just examining the appearance of the malignant cells under a microscope. So we have M0 to M7. I don't know how to, there's no way of simplifying these ones that are found. You just cram them. So these ones you just cram for yourself as just with time. Related to that. So genetic abnormalities are responsible for the mutation of the myeloid precursors to form the myeloblasts. So you can either have deletion, which is deletion of some segment of the DNA, duplication. So this is just doubling of some section of the DNA, or inversion, where a section is just stamped like upside down. Yeah, translocation is also another genetic abnormality that is a hallmark for leukemias. So this is like PBF, peripheral blood film. You can tell, you can just identify the blasts, the myeloblasts. All of these purple ones are myeloblasts that you would observe under a microscope. So this just goes deeper into the classifications and how to differentiate the different types of AML. Sometimes you just, there's really no way to simplify these things. Mm. 6, 7. So, pathogenesis, we mentioned some of the causes that can cause, some of the things that can cause leukemias, like chemicals, viruses, stuff like that. So that one we won't really mention. So treatment, most of these ones are treatable by chemotherapy. This we've also mentioned for in general, the different types of tests that you can do to identify the leukemias. You can do a full blood count or peripheral blood film, bone marrow aspirate. You can do a bone marrow trephine biopsy, cytochemistry, or immunophenotyping. So when you're trying to diagnose acute leukemias, this just relates to the staging. So you have to really just observe under your microscope mm, the blood or the bone marrow. Then just count the number of blasts you would see, or just identifying the presence. So these are some of the stains. This is now the right stain. Can identify the erythroid precursors. This is all the statistics that is involved in the diagnosis. So the stains involved Sudan Black B, myeloperoxidase. You can also have chloroacetates, alpha naphthybutyrate esterase, or periodic acid shift. So the Sudan Black is important for the identification of myelomonocytic cells, also the myeloperoxidase. Then granulocyte blast used for acetate esterase, monocytic cells, alpha naphthybutyrate esterase. Then the lymphoblasts, erythroblasts, can just use this one for periodic acid. These are just the other tests. You can do your immunophenotyping or your flow cytometry just to help diagnose. So the other way of classifying AML is the WHO classification. So we've seen two classifications now. We've seen the FAB classification, then now we're seeing the World Health Organization classification. So these ones are 5. We have acute myeloid leukemia with recurrent genetic abnormalities, then AML with multilineage dysplasia, AML with myelodysplastic syndromes or therapy related, AML not otherwise categorized, or AML of ambiguous lineage. You can't place this one in, you place it in like 201 or 2, okay, 2 or 3. On this one, you cannot, it doesn't have symptoms, or sorry, signs that are ideal for any of the groups. So when it comes to the treatments for these types, for these leukemias, it will be discussed more in Clean Farm. So the next type is ALL. Before we do ALL, we can just take a break. And we meet at like 9:05. Guys, we can just get back. You guys are still there?
Yes.
Okay. So we can continue to acute lymphoid. So of course, this one refers to the leukemia that affects the lymphatic cells, the lymphoid cells. So yeah, there are three major categories: ALL with fairly small uniform lymphoblasts, ALL with more pleomorphic lymphoblasts, or ALL with basophilic vacuolated lymphoblasts. So classification, as usual, is quite broad, and you just have to cram it. If I don't really see the point of it, I don't know if it's gonna be asked. But what you need to know about this one is that it is known as the childhood leukemia because it mostly affects children. It's most common between people who are 2 to 10 years old. So it's most commonly for children. Etiology is just like in the other one. You can have your chemicals or your toxins, radiation, viruses, or genetic and congenital factors. So the presentation for this one is always like threatening. We have anemia, leukopenia, thrombocytopenia, hepatosplenomegaly, and gum hypertrophy, and also skin infiltration. So the symptoms will like coincide with, now you know, for like anemia, you'll have lethargy, dyspnea as your major symptoms because of the reduced oxygenation of the body. Leukopenia will lead to infections like in the mouth, skin, on the perianal region. Then thrombocytopenia means the patient will bruise easily because they just leak blood easily because of the platelets, menorrhagia, and also gum bleeding. So you can have differential diagnosis. So some conditions can be confused for ALL. So the lymphadenopathy can sometimes point to infectious diseases such as mononucleosis. The hepatosplenomegaly can also be confused for myelo or lymphoproliferative disorders. So you just have to really do your homework when it comes to this one, where your homework involves your investigations, full blood count. I will usually show hemoglobin and platelets below 20. You just have variations of the cells that are implicated, even if it's lymphoid. The progenitor cells, maybe if the blasts are affected early on in development, it affects all the bands. So these are some of the tests that you need to do. Of importance to note for this one, in the investigations, there's this thing called the Philadelphia chromosome. It is most commonly implicated in this one, ALL, and now in what we'll see later, chronic CML, chronic myeloid. So Philadelphia chromosome is shortening of the chromosome 22. So I don't know about, I think this slide was in reference to CML. So Philadelphia chromosome is less common in ALL than it is in CML, but in most situations it's usually there. So it's a major indicator of whether it's ALL or the AML. So you can try to distinguish using the Philadelphia chromosome. This helps to diagnose, that is. So in ALL, some of the things that give a poor prognosis, we have the age. So if it affects a child who is less than 1 year old or over 10 years old, that's a very poor prognostic factor. So it means the chances of recovery are very low. Being male is a poor prognostic factor. Having a white cell count at diagnosis of less than 50 times 10 to the power 9 per liter is also a poor prognostic factor. Having blasts in the CSF, which indicates that the disease has traversed the CNS. Immunophenotype, B or T, different subtypes. Having the Philadelphia chromosome is a poor prognostic factor for this one. And then lack of remission after one course of chemo. So these are just the different morphologies based on the FAB classification. We have the L1, L2, L3. So these ones are the ones we mentioned at the beginning. So immunophenotyping is another diagnostic way that we mentioned. It's implicated. It's a commonly used tool for like all the leukemias, where you could just identify the surface proteins present on the various cells. So these are the diagnostic profiles for AML. You can see we use CD13, CD33. So the various cells that you will identify. Cytogenetics, this one is what will help you identify the presence or absence of the Philadelphia chromosome. So we mentioned this poor prognosis with Philadelphia chromosome. So also hyperdiploidy, which is increase in the total chromosome number, is good prognosis. And then hypodiploidy is poor prognosis. Okay, we can start the chronic leukemias. I hope it's visible. So for the chronic leukemias, we have two types. We have the myeloproliferative ones and the myelodysplastic myeloproliferating disorders. So there are quite many. You read those ones for yourselves. But we start with the myeloid leukemia, chronic nature, CML. So this one results from malignant transformation and clonal proliferation of a pluripotent stem cell characterized by increased proliferation of the granulocytic cell line. So increased proliferation of the granulocytic cell line. So that means, of course, you know, the granulocytes are the BNEs. So that just points to it being myeloid. So as I mentioned, the defining characteristic is the presence of the Philadelphia chromosome. And I mentioned that is shortening of the chromosome 22. So yeah, this is it. Mentioned Philadelphia chromosome is shortening of chromosome 22. Mm. So, this will be evidence, yeah. Does anyone know? Mm. So PCR is a breakpoint cluster region. So this is just the pathogenesis of how this type of leukemia comes along. Uh, so it, it can just be described in short as a chromosomal translocation that leads to the formation of the Philadelphia chromosome. So having this Philadelphia chromosome produces high levels of unregulated growth of the myeloid cells in the bone marrow, leading to their accumulation in the blood. So there is increased proliferation of mature as well as immature granulocytes, the BNEs. But some of these other cells, like the red blood cells, like the karyocytes, monocytes, you will also, the granulocytes are the most commonly implicated types of cells, but to a small extent, you can also have these other cells implicated. So the median for the clinical features mainly affects people at around 50. It's not common in children, and the ratio in terms of how it affects males and females is equal. So what a patient will tell you when they come to you is that they feel generally weak, they've lost weight, they have night sweats. Then when you do your physical exam, you'll find hepatosplenomegaly, they bruise easily, they have spontaneous bleeding, and chilling someone, and they have random nosebleeds. Some patients, though, are asymptomatic. There are also ominous signs such as fever, marked lymphadenopathy, maybe maculopapular skin involvement. So CML has phases. So there's the chronic phase, where the leukemic cells retain the capacity for differentiation and maturation and are largely able to function normally. So this phase, it lasts usually like 3 to 5 years. And this is the stage at which everyone hopes if you get, like God forbid, get this disease, if it's caught at this stage, it's highly treatable. Then there's the accelerated phase. This one develops in like 70% of the patients because 3 to 5 years is a short time. You might find that, especially for patients who are asymptomatic, as you've seen, it won't be caught. It's most of these things are usually caught serendipitously. It's accidentally. You're going to hospital for something that is unrelated to this. They do a profile of your blood, or then they realize, these results are weird. So they do more investigations, and then they discover you have some of these problems. So the second phase is the accelerated phase. It occurs in like 70% of the patients in whom it wasn't caught in the first phase, the chronic phase. So leukemic cells show increasing loss of differentiation and increased proliferation. In this stage, there is resistance to chemotherapy, and anemia and thrombocytopenia become worse. The last stage is called the blast crisis. So this occurs when there is transformation to acute leukemia. So at this stage, it is extremely resistant to chemotherapy. This is why your doctor tells you have like 6 months left to live. And 30% of patients proceed directly to the blast phase without even going to the accelerated phase. So the accelerated phase is like the median phase. Not every patient goes to it. So for the lab features, full blood count would reveal normal or decreased red blood cells, because mostly, as we've said, it's the granulocytes that are affected. So the white blood cells, because this is the total count is going to be moderately or markedly elevated because of the granulocytes. Then the platelets, just like the red blood cells, can be normal or slightly increased. Peripheral blood film, the red blood cells will look okay. The white blood cells will reveal leukocytosis, where all stages of maturation are present, with peaks of myelocytes and segmented neutrophils. Then the basophils and the eosinophils are slightly increased. Platelets more or less normal or slightly increased. So the other way you can do your diagnosis or the investigation is bone marrow examination. So hypercellular marrow with markedly increased granulopoiesis. So the granuloblasts, the different precursors for the granulocytes, the immature ones are the ones that are mainly going to be implicated. So you'll find the ME ratio. ME ratio is the myeloblast or erythroblast. I don't remember. Or it's 10:1 to 50:1, but the normal is usually 2:1. So, pathology. Neutrophil alkaline phosphatase score. So this one is also another finding that you get. The normal score is 40 to 100. So deviations from this can help you diagnose. UECs, you will find hyperuricemia. Vitamin B12 will be elevated. Cytogenetics, of course, we've said you will definitely get the Philadelphia chromosome. Okay, I found that B12 can be elevated because what's it called? The bone marrow is favoring formation of the granulocytes over the red blood cells. That's why you find sometimes that the red blood cell count will be slightly decreased. So the vitamin B12 is not being utilized more than normal, as normal, so it will be elevated. Philadelphia chromosome. Okay. The accelerated phase, of course, you now find more blasts in the marrow. Then the blast phase, the blasts develop now, they are released into the blood, meaning you have the immature cells that basically are not able to fight off infections. So they're now present in the blood. Now this one now presents like an acute leukemia. So these are just some other conditions that you can confuse for CML, leukemoid reaction. If you diagnose the patient at the chronic phase, you need to differentiate between leukemoid reaction, other myeloproliferative disorders, or chronic myelomonocytic leukemia. For patients in last crisis, diagnosis of this one, because it behaves like it's an acute myeloid leukemia, you cannot really differentiate a patient in last crisis from a patient with AML. So the Philadelphia chromosome is what can be of help to differentiate, because it's not usually there in AML. It's there in ALL for some patients, usually roughly around 25%, but not in AML. Talked about this. So you can also have chronic neutrophilic leukemia. This is a rare disorder characterized by persistent peripheral blood neutrophilia, bone marrow hypercellularity, and hepatosplenomegaly. Unlike leukemoid reactions, it is not associated with fever, infections, inflammation, or malignancy. So this is just another condition that you need to properly differentiate between it and our CML. So the way it looks when you do your investigations, persistent leukocytosis, segmented neutrophils, and bands account for 80% of the differential counts. From the name, you can tell that the neutrophils are the ones that are implicated. Now, not all the granulocytes, it's mostly the neutrophils. And then in the bone marrow, you'll find hypercellular, will be hypercellular with marked granulocytic preponderance, which is just a fancy way of saying there will be a lot of granulocytes. You can have chronic eosinophilic leukemia, same thing, but now for eosinophilia. It's eosinophils, that is. And then the other one is chronic myelomonocytic leukemia. This is now for monocytes. The next thing is atypical CML. This is a clonal hematopoietic disorder characterized by both dysplastic and proliferative features, including persistent granulocytosis, bone marrow hypercellularity with dysplastic hematopoiesis, myeloid preference negative, Philadelphia chromosome, and lack of basophilia. So it's atypical mostly because of the negative Philadelphia chromosome. It's myeloid, but it does not cause change in the Philadelphia chromosome, chromosome 22. Juvenile myelomonocytic leukemia. This is for early childhood, characterized by some of the same symptoms: hepatosplenomegaly, granulocytosis with monocytosis, elevated hemoglobin F level, and skin involvement. Now the next one is CLL, chronic lymphocytic leukemia. So this one is a monoclonal disorder characterized by progressive accumulation of mature, functionally incompetent lymphocytes. Most are the B cell type. So this one is something that we need to note. Most implicated cells are the B cells, and a small percentage are the T cells. So classification is based on the type of cell, of course. So we'll have the B cell or the T cell and another B cell. There are also some other types, the precursor B cell, lymphoblastic lymphoma, B cell CLL, B cell prolymphocytic leukemia, hairy cell leukemia, now for the T cell. So anyway, in general, all these usually have kind of similar features clinically. So they occur in patients over 50 years as the first thing. Prefer males to female in a ratio of 2:1. You'll have patients who present with repeated infections and symptoms related to anemia and thrombocytopenia. So like the bruising, the bleeding, the fatigue, and the lethargy because of the anemia. We'll have lymphadenopathy. Then for this one, we'll have mild to moderate hepatosplenomegaly, but about a quarter of the patients are asymptomatic. So for CLL, the exact cause is uncertain, and but the proto-oncogene BCL2 is overexpressed, leading to the suppression of apoptosis in the affected lymphoid cell. So from this, you can tell that the BCL2 gene is responsible for the induction of apoptosis in the lymphoid cells that are produced with problems. So the lack of the programmed cell death leads to now these increased levels of the problematic lymphoid cells, leading to now this condition. For this one, most are diagnosed without symptoms just by routine blood tests. And the blood tests will just yield high levels of the white blood cells. This one, a full blood count will reveal this information: anemia, increased white blood cells, with over 80% of them being lymphocytes. Platelet count can be normal or decreased. So of importance in terms of the lab features is 80% of them, of their white blood count being lymphocytes. For the peripheral blood film, the leukocytes will be many, and they will be small, mature-looking lymphocytes with high NC ratio. And then you'll also have prolymphocytes and cells that are called smudge cells or basket cells. Platelets, as we've said, they look normal, or they can be reduced. Yeah, just the expected findings. Bone marrow aspiration can show normal cellular or hypercellular marrow, and the patterns of infiltration can be diffuse, interstitial, nodular, paratrabecular. Yeah. For this one, you can do the Combs test to document autoimmune hemolytic anemia, and flow cytometry, where now the CLLs are morphologically indistinguishable from normal cells, but with immunophenotyping, the cells express weak surface ID markers and B cell markers. So these are some of the markers that you will expect to see after you do your flow cytometry. So prognosis, females have better prognosis. The Rye or Binet stage CD38 markers for poor prognosis, for good prognosis. So that is cytogenetics using the fish is good prognosis. And this now are the just based on the classification, as we've said here, you can use the RAI or the Binet staging classification. This ones you just read for yourselves. There's no real way of understanding, so you just have to know. This is the criteria to declare a patient to be in complete remission. So should have no symptoms, normal physical exam, lymphocytes should be above 4 × 10⁹ neutrophils. These are the values for all of them. Hemoglobin should be above 11, and the bone marrow lymphocytes should have less than that, should be less than 30% with no nodules. Complications of CLL. So of course you'll have infections. Your body is not able to fight infections well, so you're very prone to some of the infections, whether they are from really kind of harmless pathogens, but to you, since your body is not able to fight them efficiently, they become serious infections. You can also have Richter's syndrome, a large cell lymphoma that develops in around between 1 and 10% of patients. Prolymphocytic transformation, increased risk of secondary malignancies, or something called paraneoplastic pemphigus. This is Richter's syndrome. So lymph node biopsy is indicated in a patient with known CLL with adenopathy, with lymphadenopathy, to assess the possibility of transformation to a high-grade lymphoma. So when the transformation to a high-grade lymphoma is accompanied by fever, weight loss, and pain, it is termed as Richter's syndrome. These are just the explanations of the complications. The other type of leukemia is hairy cell leukemia. This one, it was in the classification based on the morphology, the B cell. So this one is indolent mature B cell lymphoid leukemia. It's rare, and the median age of presentation is 55 years with male dominance. Clinical presentations are related mostly to splenomegaly and pancytopenia. So I tells you the anemia, the bleeding or bruising. Yeah. So in this one, there's proliferation of medium-sized lymphocytes with cytoplasmic hairy projections involving blood, bone marrow, and the spleen. So the hairy projections are the ones that are responsible for it being called hairy cell leukemia. Yeah. So in summary, for all this, not just for even chronic leukemias, the major thing that is important for these things is the lab work, the full blood count, the peripheral blood film, the immunophenotyping to identify now stuff like the Philadelphia chromosome, to identify the Reed-Sternberg cells. So all these things are what's important to be able to differentiate between one disease from the other. So yeah, the type of important. With that, we are done with the chronic leukemias. Guys, the next topic is a bit long. I think we're going deep into platelets formation and now problems related to platelets. So we can do that tomorrow because it's also, so it's not a small topic.